Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920, WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Pamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to bring this program to you. Help us by mailing your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York 12402. For more information or to donate online, visit our website at mykcr.org. Good morning, this is Dan Gatis, and thank you for tuning in and sharing the morning with us. Being early birds like this, 24 degrees right now here on this Monday, January 10th, and we'll be right back after these messages.
Okay, let's settle down. Since today is career day, stand up and tell the class what you want to be when you grow up.
I want to be a pilot,
soccer player, fireman,
a judge.
Kids dream big. As a parent, you can protect those dreams by keeping your kids healthy well into adulthood. If your son or daughter is 11 or 12 years old, the American Cancer Society recommends giving them the HPV vaccine to help protect them from 6 types of HPV cancers later in life. To learn more, visit cancer.org/dreambig.
Introducing the YMCA. What, you already know the why? Or so you think. Sure, you know the why for a swim, a workout, even a game of hoops. But did you know we're more than that? We're a cause. When you take your jump shot at the Y, someone else is getting job training. Take a cardio class, while kids are in an after-school enrichment program. Practice your downward-facing dog as a teen practices her leadership skills. That's the why. We work with people no matter their age, income, or background and give them the opportunity to learn, grow, and thrive, all with one simple goal in mind, to strengthen our community. And we've got so much more that does just that. So while you might think of the Y as that place for lifting weights, we're also about lifting entire communities. Introducing the Y. We're so much more than a place. We're a cause. Visit ymca.net/more.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
And we're back again. You're listening to KCR, Kingston Community Radio, AM 920 and 92.5 FM. This is Medical Monday with Dr. Eric Stamberg and Robin Baker. Sun and clouds mixed today. A few flurries or snow showers possible with a high of 27. Partly cloudy tonight with a low of 9. Single digits for tonight. And Tuesday, sunny, very cold with a high of 17, but a sunny day. And clear skies on Tuesday night with a few passing clouds, a low of 8. So we are seeing winter wonderlands here. And Wednesday, partly cloudy skies with a high near 35. It goes up a little bit higher on Wednesday because of the clouds. And Wednesday night, mainly cloudy with a low of 22. Now let's get back to the on-air studio. By the way, the on-air studio is wherever Dr. Stamberg is.
Is that right?
And good morning. How are you, Dr. Stamberg? How are you?
All right. Good morning, Dan. I am here with Robin. Say good morning, Robin.
Oh, wow. You guys are together, so I can keep a phone line open for call-ins. That's great. 331-9255. 331-9255 is our call-in number.
We also have 2 cats assisting with this morning show.
That's excellent. Okay. All right. Great companions.
Robin and I are calling in because she and I are under quarantine due to COVID exposure, and we are being good citizens.
Absolutely. Absolutely. Thank you for that. Thank you.
Sure. Now that, I've potentially been exposed, I turn back the clock and I say to myself, did I do a good enough job, protecting myself and protecting others? So there's one message to kind of get out to people this morning is to continue to be careful and really do our best to protect ourselves and each other. Would you agree with that, Robin?
Yeah, it's really easy to just, get a little bit laissez-faire about,
going anywhere. So it's just so. How would you describe the uptick right now? It's just so contagious.
Right. People ask a lot about the Omicron thing. By the way, I guess we should say there's a little introduction first. So we'll be here till 9 a.m.
Yes.
And we're able to have a phone line open so people can call in with questions or comments. We do have a guest calling in at around 8:15.
Oh, fantastic.
Dr. Naj Hachandani. He is an internist, and he just recently started practicing in Highland with New Vance. So we look forward to talking to him.
Right, and he's a GP, right? So
he's a general.
General.
Primary care medicine. Usually, when people say primary care, usually referring to three specialties. You're referring to general internal medicine, family practice, and pediatrics. And then there's always been kind of a debate whether or not OBGYN kind of gets pulled into that category as well.
Well, because family practitioners are trained in OBGYN.
We are, but OBGYN, the other way to look at it, though, is that OBGYNs provide a lot of primary care to women, particularly prevention with breast cancer screening and cervical cancer screening. So anyway, that's a discussion for another time. How do we get on that tangent already?
Well, because there's the three specialties for primary care.
Right.
It's a little bit, the lines get a little blurred. We have a cat fight going on here. I don't know what's happening. The lines get a little blurred because just of what kind of training you get in medical school.
Right.
And an internist like Dr. Hachandani doesn't see kids, right? And one of the things about being in internal medicine as opposed to family medicine is that a doctor like yourself sees from birth to death, from babies, and you take care of pregnant women, and you take care of children up to age 18. An internist isn't allowed, can't really practice or see children under the age of 18 under their license.
Right, and on the other side of the coin is some of the training of an internist is more involved than in a family practice training.
Gotcha.
There's only they're both 3-year residencies, so there's only so much ground you can cover.
3-year residency after 4 years of medical school.
The U.S. system, has medical school really start after college. If you talk to European systems, they really have medical school basically be college. They call it university.
Right, but it's an 11-year adventure in America.
Minimum. If you count college, yes. It's an 11-year kind of minimal commitment to when you start your education to when you're ready to fully practice.
Right.
That's a big matzo ball.
And Dr. Hachandani, am I saying that right?
No, Hachandani.
Hachandani's dad is also an area physician.
Right, he's a gastroenterologist who's been practicing in the Poughkeepsie area for a long time.
Which I have to say I got a lot of respect for. When you have a physician in your community and, they have a child or maybe several children and the children decide to also go into medicine. But,
I'm 0 for 3, by the way.
But most kids, they're like, bye, and they'll see you around, But it's kind of nice to come back to the community where you're from. Right,
and it's okay to see kind of medical families go on.
Yeah.
So there's a couple other good examples in our community of second generation physicians. So anyway, so let's go back to what we were talking about, which was what's going on with our community with Omicron.
Yeah.
I am hoping that this is the beginnings of the virus kind of mutating. Mutating might not be the right word, but it's something I think people understand.
Yeah.
Yeah. Mutating into a less virulent form. So the rules, what we talked about last week, that was last week with Dr. Tack, that it's very contagious. Probably more contagious than any other strain we've seen of COVID virus since then. In most cases, it appears to not be as serious. Now, that sends kind of a message out there that can be a little confusing to people. Therefore, let's not care about it. Therefore, let's just let ourselves get it. You remember, talk about things like chickenpox parties and
yeah.
And I think even the measles parties occurred before chickenpox parties. But it's still kind of a numbers thing because so many more people are getting Omicron right now. Even though it's less likely to be serious, there's kind of just as many people with serious cases. So it's still something to be concerned about. Being exposed, you and I am very grateful for being vaccinated and boosted, because I know that gives us
a leg up.
So once again, I've been rather consistent with this to really implore people to get vaccinated. And if you have been vaccinated, to get boosted. I think people have been kind of maybe dragging their feet a little bit on getting boosted. And I understand that, a little bit of COVID fatigue. And then when the vaccine came out just a year ago, well, gosh, it feels like a lifetime. But, it was exciting, right? Remember that?
Yeah.
Here we are a year later. There's a lot of arguing over the vaccine. Really, I just want people to get it. But I had a patient say to me, actually, I think this patient was vaccinated, but I was talking about getting boosted. And he said he really wishes it wasn't so political. And I said, I don't think it's political. I'm your doctor. You're my patient. I'm advising you to get this booster. That's not a political statement.
You think it's along the lines of you saying to a patient, your blood pressure is this level. I'm going to give you some medicine. I think you should take it.
Or even just kind of quit smoking and, and watch your diet and lose some weight. It's health advice that I give all day long, and it's not political. That if you whittle it down to that basic statement of get your vaccine and get boosted, that is not a political statement. So I really wish people would just disavow themselves of that notion.
Right, because you might smoke your whole life and never get sick, right? But you might smoke, just a couple years of your life and get sick. So, yeah, there's a chance you could get sick. There's a chance you might not get sick. But the doctor's advice is to not smoke.
Correct. And that's not a political statement.
Right.
All right. So the cases are still up. Where the jury's a little bit out on well, let me just say, I'm going to backtrack a little bit. The hospitals are still full. The Northern Dutchess, which is where I work, the census of cases that are COVID-related in some way, about a third of the cases. That's high. All right, that's a lot of volume, and I can't imagine the numbers. Numbers might, I think, are even a little bit higher at Kingston Hospital. I think because the city in Kingston, unfortunately, I think has a lower immunization rate. We're seeing a higher effect on the hospitals. So,
yeah, and the rules haven't gotten less either. The rules with masking, the rule. This is the advice.
Yeah.
Like nobody, right? This is that thing where nobody's getting arrested if they're not wearing a mask.
No.
But it's advised to wear a mask. And you're advised to wear a mask not just to protect yourself, but to protect the other people around you.
I think there's
a lot of pediatric cases that are happening now.
Yes.
Kids 5 and under, they don't have an opportunity to be vaccinated.
Right.
And they're getting sick.
Pediatric admissions are way up.
Yeah.
Thankfully, and this is good news, there are very few pediatric fatalities. I don't think that should be used as an argument against the seriousness of this infection. I mean, plus there's a lot of long-term effects of this virus that we know nothing about. Cardiac effects, cognitive effects, respiratory effects. I read there was one report that they were discussing on a morning cable news yesterday showing that pediatric COVID survivors have a higher risk of diabetes. That made me scratch my head a little bit because it's only been a couple of years. How they already know that. It's really just kind of one report. It's kind of a mistake to draw dramatic conclusions from one report, but it does kind of show how this virus it really affects your whole body, and so to kind of say, no kids die from COVID. First of all, that's not really true. At this point, we have around 850,000 fatalities in our country, and there are plenty of cases within that of young people, but that doesn't mean by any means that it's something you should want kids to get.
Right. Absolutely.
So get boosted, get vaccinated if you haven't been, get boosted if you haven't been, protect yourself, continue to wear the mask. The N95 is kind of the way to go, although it's tough. It takes some getting used to. I feel it's kind of like wearing a new pair of glasses. You know, at first it's kind of uncomfortable, but after an hour or two, you kind of not even aware they're there.
Get used to it.
Yeah.
And the 6 feet distancing rule.
Yeah.
Washing your hands, making sure you're using your hand sanitizer, and you know, all of those things that, boy, they don't really bother us that much. I mean, I remember when everything first happened and you started being aware of what you actually touch. And I remember me and my friends saying to each other, do you know how much I touch my face?
Yeah.
I touch my eyes. I touch my nose.
Yeah.
I touched I was never even aware of it. And boy, now are we, hyper vigilant and aware of it. And really, I think most people are really trying to do a good job to, keep themselves safe.
Right. Okay. So, we'll get back to that. There's other elements of what's going on with COVID. We'll try to visit later on. There's some newer treatments with the pill, and still some issues with antibody treatments. I want to talk about the flu because we're seeing it. The flu's out there.
So when you are having a little bit of, let's say you get sniffly, or you get a little congested, which is, I would describe those types of symptoms as, in the past, something I would go to work with. Like, I don't have a fever.
Right.
I don't have, like, severe malaise that I can't get out of bed. I feel a little under the weather. But I know that that's the case right now, that if you even have a little bit of a sniffle, you really should be tested. Because, and I know that there's a shortage of rapid tests, but the truth is the rapid test is very good at letting someone know if they're positive or not.
Right. Yeah, yes. The rapid test is the place to start, but if you are having symptoms,
even mild ones.
Right. You really, if the rapid test is negative, we shouldn't be lulled into a false sense of security with that. It should be followed by a PCR, which I call a send-out.
And you get that through your physician or the local urgent cares. I know the Macy's site, the New Dance Urgent Care, I believe, has them as well.
Well, right. It's interesting. It's an interesting story. But the places you can get tested, first of all, there is home testing. Home testing, I find that a little controversial because you and I even bought a couple weeks ago. Within a couple of days they were used up with my kids and whatever. But $25. Well, maybe it was $23 for a set of two.
Yeah, that's a lot of money, don't you think?
Kinda, yeah. And in a way, I was online over at Walgreens, and they had it right there. So you could try to purchase your home test, but they have been flying off the shelves. And, even though it's not hard to do, it's still kind of a medical test. You're really putting a lot of faith in the individual that they're going to be able to follow these instructions correctly. I got a new coffee maker. I'm having a hard time using that. So keep it in perspective.
So if the test is negative,
the rapid test, yeah.
you have symptoms, even if they're mild.
Yeah, you should have a PCR and what's called a send down. It's a place you can get that. There are, but it's been a challenge because there's been such a surge of demand. The county's running a couple sites. It's always reasonable to start with reaching out to your physician or healthcare provider. I think if I could toot the horn of my own organization, I think that Nuvance has done an amazing job at mobilizing providers and making them more available for people in need of testing. There was, even just 1 or 2 weeks ago, the urgent cares. I can't believe we use this word, but the urgent cares were virtually overrun by people needing COVID testing. And not to say we're out of the woods, but that wave may have crested. So, again, I'm just going to give kudos to Nuvance, but I'm sure by no means is Nuvance alone. I know that the people over at Emergency One and Hurley Ave and other places are working very hard to meet the needs of the population.
So let me ask you this. Is it that you're seeing the surge due to the holidays? Was this like a Thanksgiving get-together? There was a surge. There's a Christmas get-together. There was a surge.
Yeah.
There's now the New Year's get-together. which here we are a week out from New Year's.
Yeah.
And just in that natural order of things, a surge from those get-togethers. Is that?
Yeah, even though COVID can kind of, be overwhelming very quickly, a lot of the more serious cases, they kind of are insidious. They kind of present like a cold, a virus, not much different than any other type of infection. Remember, before we had COVID-19, the family of virus, coronavirus, has been around forever. And it has been a cause of the common cold. The difference was that this COVID-19
kills people.
So virulent, yes, and that's the difference. So the surge, it tends to, most serious cases, in my experience, tend to be people who have been sick for anywhere from 1 to 2 to even 3 weeks, just people who just haven't been getting better gradually. I tell patients there's a difference between COVID-19 infection and COVID pneumonia. So COVID-19 infection, in a way, is kind of like a cold. It could be a bad cold. It could be a mild cold, a moderate cold. But COVID pneumonia is kind of what it sounds like. It's now in your lungs. So you'll have shortness of breath is pretty much the cardinal symptom. You're unable to breathe, and that's a scary thing. So, yes, the surges based around gatherings tend to follow the exposure by 1, 2, 3 weeks. So, yes, we saw our Thanksgiving surge around the time of Christmas. We may have already seen the Christmas surge, and I'm not so sure we're out of the woods yet. But as I said, the census over Northern Dutch is still about a third of inpatients have COVID in some way, and that's high. For months it was 2, 3, 4, 5 patients. Now it's about 20 patients, and I'm sure it's more at Kingston and it's more at Vassar. These are bigger hospitals, so they'll have more patients.
So what is your advice? You're having mild symptoms. You have an at-home test. You take it. It's negative. Contact your physician and you let them know you took a negative test, but you're having these mild symptoms. They suggest you do a PCR. Are you automatically also doing a flu test? Is this something that everyone should be doing just to rule that out?
What an amazing segue. You must have been reading my mind, because the flu is out there. So we, in our office, we have our rapid test. Actually, is now a combined test of the COVID, the SARS virus, and influenza A and B. So it's kind of the same test. Not every site has that. They might still have separate tests of the COVID test. And the
wait.
test.
So you mean it's 3 tests in one?
Yeah.
So it tests for flu A?
But that's a rapid test, but yes.
So it tests for flu A, flu B, and COVID-19
right.
in one swab. So
One
you only
swab.
have to take one of those nasal.
They'll tell you if you're pregnant, too. It does a lot of things.
Don't listen. That's not true. That people don't they don't understand.
That was a joke. So, in the office now, we have a rapid test that will test you for flu at the same time. And that actually comes from the State Department of Health. That really, if you're going to test for COVID, you should also be testing for the flu. The symptoms cross over into each other. Treatment is different. And we're starting to hear, about people kind of having both at the same time, giving kind of cute names like Covenza, Flurona. No, it's in the news. Look it up. They keep giving this name to like the people who kind of have COVID and the flu at the same time.
Like Brad and Angelina, like one of those marriages.
Yes.
All right. So, but with symptoms, you should definitely be tested for the flu as well as the coronavirus.
Yes. Because
there's a different treatment.
Different treatment, and it has different ramifications on how a patient should be counseled. People who have the flu should be, isolated, but it's not quite to the same level as what we're trying to do with the COVID infection. Maybe there's differences in return to work guidelines. Again, the treatment's different. We still have a medication that's used for the flu called Tamiflu. I don't think I ever prescribed it at all last year because the flu season was so quiet. But the cases right now of the flu are out there, and both influenza A and influenza B are out there. So what's the take home from that? One is to remember, before we talked about COVID, we talked about the flu, and you should also be getting your flu shot.
And you're not just necessarily seeing these flu cases in your office. You're actually seeing flu cases in the hospital where someone is very sick.
Yeah.
And they do not have COVID, but they have the flu. The flu is severe enough to be hospitalized for it.
Right. That's right. And so the rapid flu test has improved in recent years. So it's kind of considered good enough, kind of in quotes. You don't have to do a send out to the flu. You could. There's a product now called the Biofire. I don't know where that name comes from. But it's kind of a panel of many different things. The other viruses that people really don't know about, like adenoviruses and things like that. But it's actually a great tool. It does a couple things. First of all, it helps identify something like the flu and something like COVID. It will tell you if your symptoms are caused by another infection. It also will help a guy like me decide, if you need an antibiotic or not. Remember, before we had COVID, we talked a lot about antibiotics, right? And trying to be judicious and cautious in how often we prescribe those.
Right, not taking antibiotics for every little thing because
right.
Not
so
good
this
for you.
test called the Biofire Test is really very helpful. We've used it in the hospital setting. I had a patient who had it done by another doctor's office, and it tested positive for para-influenza. That's a virus. Now, it's called para-influenza because it's kind of like influenza, but it isn't. So it's right next to the influenza. That's why it's called para-influenza. It's just a virus. It runs its course. But that patient kind of, called me saying she had the flu, and I had to kind of explain to her, you don't have the flu. You have para-influenza, which is really just kind of a cause of a bad cold. But
it's really not easy for the layman like us to understand the differences between what you're talking about.
Right.
So it's very important to, have that good connection with your doctor so that, you can have that sense of peace that, you're getting that right information.
And I'm cautious about that. This person received this test from a provider who was more than happy to do the test, but didn't really help the patient interpret the results, which was kind of a no-no. So that's where I had to kind of step in, even though I didn't do the test.
Right.
The test was, you showed this, call your doctor. That doesn't help. Either. So
well, she had you, so she was okay.
Well, I was able to disavow her of her concern that she had the flu. By the way, it was also a completely non-flu season. So it was just an unusual result to get in the middle. I can't remember when it was, middle of the summer or something like that.
Interesting.
But the Biofire is a good test. And I look forward to kind of using it more as time goes on. I get a problem with that. I think we talk a lot about the business of medicine, which is that, payers, otherwise known as insurance companies, don't always jump on something. Just because the test is available, it can be helpful, doesn't mean that your insurance is going to cover it.
Yeah, sometimes you can't get vitamin D testing, so.
Yes. Vitamin D testing, the paradox of Medicare and paying for lab tests. I can't test someone for vitamin D deficiency unless they have vitamin D deficiency. But I don't know if they have vitamin D deficiency unless they test them for it. This is like catch-22.
It sounds like the Marx Brothers.
Yeah, right. Anyway. So
you're having mild symptoms of what you don't know.
What?
You're having mild cold symptoms.
Yeah.
You take the at-home test. It says it's negative. You reach out to your doctor. You want to get a send-out test. You want to test for flu and COVID.
Right.
So let's say your symptoms continue.
Yeah.
I know we talked to Dr. Kapp last week, and he was not of the same thinking as those new guidelines that came out. He believes that the 10-day symptomatic quarantine is very important to keep everyone healthy. And you were talking about some new treatments, because really the treatment is to stay hydrated.
Yes.
And take care of yourself.
Yeah.
Kind of as if
kind of a cold. Well, it's not. I shouldn't call it a cold, but it's a viral infection.
1 minute, folks.
That's Dan.
Will you say something?
Yeah, I just said 1 minute, folks. 1 minute to break.
1 minute to break. Rob and I, by the way, are sitting over a coffee table. I feel a bit like Regis and Kathy Lee here.
That's fantastic. That's beautiful. Now you have a good conference call coming in.
So what were we talking about before? Dan gave us a 1 minute warning.
Sorry.
We're such amateurs, Dan. I'm sorry. So the symptoms are very similar to just many other viruses. So you treat it like that. Rest, Tylenol, ibuprofen, cough and cold remedies, chicken soup.
Right. But potentially, these symptoms could worsen, and you really have to take it seriously.
Yeah. My daughter Sarah recently tested positive, and then after about a week, she's still kind of not better. She feels a little bit in her lungs, and I think she has a touch of COVID pneumonia.
These are healthy young people that are just not feeling good. By the way, vaccinated and boosted too.
Yes, and thankful for it.
Yep,
right,
keep that thought, Eric, and we'll come back after a couple minutes. Please keep that thought. Yes, we are at the 7:30 break, and you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. My name is Dan Gaddis, and you're with us here at KCR on a Medical Monday with Dr. Eric Stamberg and Robin Baker. It's Monday, January 10th, 24 degrees here in Uptown Kingston. We'll be right back after these messages.
Are you a renter or homeowner having trouble paying past due electric and gas bills? The Regular Arrears Supplement Program may help. If you're eligible for the program, you could receive up to $10,000 in aid. If you're behind in rent payments, the Emergency Rental Assistance Program may also help. Get the relief you need to help pay off those bills. Visit the Assistance Programs section of centralhudson.com for eligibility and application requirements. Do you know who that is? Who's that? It could be a clever thief impersonating Central Hudson, asking for your personal or account information, or an immediate bill payment. Beware of scam artists that can target you by telephone, email, or in person. Don't provide personal information to callers or open email attachments. Ask to see ID. If you're ever uncertain about an inquiry, contact us. Don't fall victim to a sinister scheme.
Hi, this is Eleanor Arrow from the town of Ulster, and I support Kingston Community Radio, and so should you.
And thank you for being with us here at KCR, Kingston Community Radio, AM 920, 92.5 FM, and streaming online at mykcr.org. And for today, a little bit about the weather and forecast for our region. Sun and clouds mixed today. A few flurries or snow showers possible. That's about a 20% chance. And a high of 27 today. And partly cloudy tonight with a low down to 9 degrees. And Tuesday, sunny, very cold. Our high for the entire day tomorrow is 17 degrees. And Tuesday night, clear skies with a few passing clouds, a low down to 8 degrees. Single digits. And Wednesday, partly cloudy skies, a high near 35. And that means that, the temperature is rising a little bit. And Wednesday night, mainly cloudy with a low down to 22. And this portion of Kingston Community Radio has been brought to you by Central Hudson. Let's get back to the our guests who are remote today, and go back for this 7:30 hour. And we're back with you, Dr. Eric Stamberg and Robin Baker.
All right, good morning. Welcome to the second half hour of this morning's show. We shall be here until 9. If you have any questions or comments, please call at 331-9255. Dan,
Yes.
What did you say temperature is only 9 degrees?
8 degrees. The low is 8 degrees on Tuesday night, tomorrow night. And tonight it is 9 degrees. It's true. It is true. And also, I just want to mention that at the 8 o'clock hour, I will announce the Boyce Dairy Milk House birthday.
Yes, you enjoy that.
Yeah, exactly. Yep. Mm-hmm. I'm looking at a very empty studio right now. But
sorry,
but, but we all seriously appreciate your consternation about not being here.
All right. Okay. So I wanted to just review the symptoms of the flu to, kind of compare it to the common cold. And by the way, the symptoms of the flu are really kind of pretty close to identical to COVID. So that's where the kind of the
overlap
problem, right? Yeah. Usually the flu hits you hard and fast. We've all had colds. One day you're a little tired, a little achy, your throat's a little scratchy. Next day, maybe your nose starts to run a little bit. And by day 3 or so, you're feeling like you have full congestion and sore throat and achy. That is typical of a common cold, whereas the flu usually hits you faster. Flu usually has more of a fever, 101, 102. The flu usually has muscle achiness as a predominant symptom. Again, you have a cold, it doesn't make you feel achy, but the flu really, patients usually use this a metaphor of being hit by a truck, which is an interesting one.
When it happens,
Yeah.
that makes perfect sense.
Right. So there's these little clues that I picked up over the years.
They also say things like, my skin hurts.
They can say stuff like that.
So even your clothes touching you is uncomfortable and it hurts. So,
for example, another topic altogether, but bronchitis. People frequently say their chest burns when they have bronchitis. So that's
very heavy.
Yeah. So with the flu, that's kind of a couple clues, is how quickly it hits you, how high the fever is, and the predominance of muscle achiness as part of the symptoms. We call that myalgia. Algia certainly just simply means pain, and mya is a prefix that means muscle. But the symptoms of COVID are kind of like somewhere in the middle, right? It's a little variable, I think because remember, before we had COVID, we had coronaviruses. It kind of, more often than not, probably is a little bit like Category 1, kind of starts maybe a little bit gradual before you kind of get hit. So for the flu, remember there's a vaccine against influenza A. Influenza A is usually the majority of cases. It can be as many as 90% of the cases. For a long time, I used to say influenza A tends to be more serious than influenza B. It also tends to be earlier in the flu season. That being said, I'm not so sure either of those statements are true anymore. I've seen a lot of people with influenza B who are quite ill, and it seems to be kind of occurring. So recently, a couple cases of influenza B showing up. The treatment is something called Tamiflu. Tamiflu is a medicine that is specific for the flu virus. It works on an enzyme that lives in this virus to help prevent it from, we use the word replicating, prevent it from replicating and therefore stop the symptoms. The medication is more effective if you introduce it earlier in the illness. So if you have symptoms suspicious for the flu, it is reasonable to seek out care, particularly if you're a higher risk patient. I mean, what is higher risk? Age is one, usually it's at 65 and older. And any other chronic medical condition, pulmonary conditions like COPD or asthma, cardiac conditions like CHF, diabetes. Those are all kind of some chronic conditions that will increase your risk of having a problem with the flu. So one message is to really remember that before we had COVID, we had the flu. And to take that, understand that that's also something we shouldn't forget about. People should still get their flu shot. I don't know. I have a little catalog of reasons why people tell me they don't want the flu shot. Excuse me. One of my favorite ones is, I never had the flu before. Excuse me. Quarantine. I never had the flu before, therefore I don't need the shot. It's like, well, you never had tetanus before. You never had, for a woman, you never had breast cancer before. It doesn't mean you don't get a mammogram. The analogies can be going, you never had a house fire before. It doesn't mean you don't get insurance on your house. You're knock on wood. I get it. So that line of thinking is flawed.
I got sick from the flu shot.
Yeah, that's a big one. We've talked about this other years, Dan, where people will say, I had the flu shot once. A male patient will be like, I had the flu shot when I was in the Navy, in the 50s, and it made me sick as a dog. And I don't remember this, Dan, but you looked up even where that phrase comes from, sick as a dog, because I was trying to be kind of humorous and saying most dogs I know look pretty healthy, but I guess when you went back to the medieval times, dogs were not quite so healthy.
Funny.
You remember that, Dan?
I absolutely do. Yes, had to do with the fact that dogs clean up after humans.
Right.
Yeah.
Right. All right. Yes. So why would someone feel that they got sick from the flu shot? It does not cause the flu. It just doesn't. A couple things might make someone feel that way. One is
immune response.
Yeah, the immune response, similar to the side effects of the COVID shot. By the way, the side effects from the COVID vaccine much higher than the side effects from the flu vaccine.
Yeah.
A lot of your symptoms of an illness are actually caused more by your body trying to fight the illness than the illness itself. So, for example, fever is a great example. Fever is a complicated system that your body is trying to use to fight this infection. It's a debate that kind of goes on to this day, which is how aggressively we should treat fever. Now, fever can be its own enemy. It can make someone feel worse. So usually if you reach a point of a high fever and it's just making you so tired and achy and have such malaise, we do recommend that you take some Tylenol or ibuprofen. Tylenol is really the safer medicine.
As directed.
Right. So that's one reason you might think that the flu shot made you sick, because it's the immune response that we're hoping to elicit from the shot might be causing some symptoms. We do give the flu shot out during flu season, so some people might legitimately be getting the flu before the flu shot's effective. The flu shot's not 100% effective, and I think that is one of the lessons of COVID and discussions about the COVID vaccine, is that the vaccines are not always there to prevent the illness, although they do. They also will mitigate the illness, and that's an important thing to remember.
Well, I think that's a really big take-home message.
Yeah.
Because you're not trying to stop everyone from getting it. You're trying to stop people from dying from it. And science shows that is accurate. Is there going to be 100% certainty with anything? Absolutely not. But, boy, we've all been through a lot in the past year, but I don't know.
Yeah, when I recommend the shingles shot, the literature of the shingles vaccine is very specific, that it prevents 50% of the cases, but it takes that remaining 50% and makes them much milder. So it's kind of the same thing with every vaccine. And by the way, that's one of the reasons why, not with shingles, but with contagious type illnesses, remember the shingles is a reactivation of a chickenpox infection, so that's a different discussion. But things that can go through a community, like the flu or COVID, it's important to achieve herd immunity, which is an old concept of comes back to the original vaccination, which was against cowpox. Edward Jenner. They told us, medical history is very interesting, and this is like 1780s. To the point where George Washington had his troops vaccinated against smallpox. Interesting, huh? But the idea was that if you had 100 cows, if somehow you were only able to provide vaccines for cowpox to 95 of them, you would provide some degree of protection to the remaining 5. That's what herd immunity is. And that is kind of what we're trying to achieve out here. If people say, are 100% of the people going to get vaccinated? The answer is no. There is a small subset of people who should not get the COVID vaccine, but that's a small subset. First of all, there are people that had allergic reactions to the first dose. They should not receive a second dose or any future doses. There are some people with autoimmune conditions on immunosuppressive medications whose specialists, like their oncologists or the rheumatologists, might counsel them to not get the vaccine. Usually it's a question of timing. Like if someone's on chemotherapy, Sometimes an oncologist will say, don't get the flu shot for 2 weeks after getting this treatment. But again, those are unusual cases. So the list of reasons to not get the COVID vaccine and also the flu shot is really pretty small. Even things that we commonly heard are kind of questioned. For example, egg allergy. For a long time, that was considered a reason not to get the flu shot. Even that's kind of drawn into question. And I it's always important to ask people, what do they mean by allergy? People are confused by that. You know, why do you allergic to eggs? Well, I ate one once and I got sick to my stomach. You know, well, that's not an allergy. That's, I don't know, a badly cooked egg. So that's always important too, to get the more of the history regarding the reaction.
Yeah.
That's what you got to say?
Yeah, I agree.
All right. So a little bit on, so we talked about flu. We talked about symptoms out of different flu. We talked about the flu shot for the flu. We talked about the treatment with Tamiflu. Tamiflu also has a role as prevention. For example, nursing homes, kind of more pre-COVID days, would use Tamiflu as a preventative measure to prevent at-risk populations from getting it.
But you can't just buy Tamiflu.
No, it's prescription.
Yeah.
It's prescription. By the way, just a little aside to ivermectin, I thought a lot about what Dr. Tack said last week. He said if it worked, he would be prescribing it left and right. He says it does not work. I was in the news yesterday. Someone was upset that they needed a prescription to get ivermectin. You know, we have a system in this country where, you know, there's oversight over our prescription products, and for good reason. I mean, these are medications. I mean, there are other parts of the world where you don't need prescriptions. But to me, that's dangerous. You know my opinion. I think even most over-the-counter medications shouldn't be over-the-counter. You could fatally overdose from Tylenol. Why should, you know, maybe that shouldn't be over-the-counter.
Right. So back to allergies, or segue over to allergies. In this time when we're worried about little sniffles and congestion, how can we distinguish that we're not just having some allergies right now?
That's a good point. Remember, winter's dry. You know, we live in old homes. There's a lot of mold and spores and dust mites that, you know, people might have allergies to. A lot of people have, these aren't allergies, but just dryness. Wood stoves, you know, wood stoves, very bucolic, very, very romantic, right? They smell good. They look good from a hillside. But it's really not that good for you. They're very dry. People
we would put a big pot of water on top.
You could, sure. There's ways to try to.
Just to humidify everything.
You just think of all those people in the 1800s. Boy, they were dry. You know. Anyway, we're making.
It was also their only source of light. It's a little different.
Absolutely. But so we have other reasons to be kind of stuffy, and you know, all the time, and particularly in winter months. Try, you know, and it's not easy. It's not easy. I mean, you know how you usually, it's kind of like when I prescribe cholesterol medicine to someone. Remember, the number one side effect of cholesterol medicine is muscle achiness. So it's always, I say to patients, you know how you feel now. If you start this medication and a month later you feel the same, it's not the medicine. So it's kind of the same thing. You know how you usually feel. But if you start to feel kind of worse, it might be. You might be sick. Particularly the Omicron is so contagious. And the symptoms can be mild. So those extra sniffles, that extra cough, that extra feeling that you're stuffy in your nose and perhaps postnasal drip could very well be Omicron infection, and you should be tested.
Right, and maybe, trying to be hyper vigilant right now while all of this is happening would be, advised.
Yeah, that's right. So the CDC's rules confused people. And, Mark Tack, he kind of criticized them. But basically, it shortened the quarantine period of many people from 10 days down to 5.
If you've been exposed and you have no symptoms.
Right. It was based upon some science that the person is most contagious a couple of days before they show symptoms and a couple of days after they have symptoms. But once it's been 3 or 4 days later, the severity of the symptoms, the risk of shedding more virus seems to go down. But so you have to just understand the recommendation. So if you're exposed, okay, that doesn't mean you have that means you have no symptoms. The CDC recommends 5 days of quarantining. I should clarify that. Okay. That was the because they already a week later or 2 weeks later.
Right, are saying that's confusing. Right.
The initial recommendation was to quarantine for 5 days, and then for another 5 days, strict mask wearing. And again, I guess I'm going to contradict myself. Actually, I said getting the vaccine was not a political statement, but something about these new recommendations might have a little bit of a political motive in the sense that it's designed to kind of minimize the effect on the economy. People not being able to go to work, for example, for school. But,
right. That kind of stuff is counterintuitive. It makes people very frustrated. Some things that were in place in the workplace where they were allowing for a certain amount of time off for COVID because, it wasn't your regular time off or whatever. They were allowing that if you were exposed or got sick. And, this word of people pulling back that cushion, so to say, for people in work. And boy, a lot of us have been on the front line since the very beginning that never stayed home and never, worked from home, just went out there day after day after day, even when it was quite dangerous, like it still is. So,
yes, it is. No, I agree. And then I did read one article about Walmart, the country's largest employer, already kind of used those new recommendations to cut down on the amount of time that they're allowing people to stay out of work. It said from 2 weeks down to 1 week. So, so that makes a guy like me nervous. It made Dr. Pack nervous that people are going to kind of go back into their jobs still contagious. Remember, people tend to not follow recommendations completely. So if we say 10 days, maybe we'll get 8 days, of isolation. So people say, we saw all of a sudden say 5 days, there's probably plenty of people who are going to feel better after 3 days and go back. And we started the show by talking about our own behavior, how hard it is to keep, abiding by these recommendations.
Yeah, definitely. It's not easy.
Finally, a little bit of the treatment for COVID infection. The antibody treatment by Regeneron is not really effective against the Omicron, but there is another form of it that is available to higher risk patients. And there's also the new pill, which I hope I'm going to pronounce correctly, called Parvlody. Or I hope I'm saying that right. That is also for higher risk people. So if you have COVID and you fall into a higher risk category, you should consult with your medical professional to see if you're a candidate for either of these treatments.
Right. The treatments have gotten better, right?
Well, the data on this pill is quite good, that it cuts down symptoms significantly, that it cuts down on the risk of progressing to severe disease significantly. So
we could trust that scientific data, Dr. Stamberg?
Yes, we could. Oh, it's funny. We're using my phone to call. I wanted to look at the Ulster K numbers, but just understand that they're still up. The positivity rate of testing is really still about 20 to 23%. That's very high. Remember, we used to get excited when it was above 5%. So it shows you how contagious this all is.
Yeah, we're hearing about, losing community members, and, it's very sad. And
it is very sad. I have been participating in the care of a few individuals who passed away, and someone, Dr. Tack's been doing it for almost 2 years now. And, some personal connections, you and I know, things that happen, to just understand that really, if you have not been vaccinated, get vaccinated. If you have not been boosted, get boosted. And if you know anyone in your family or circle who hasn't, really try to talk to them,
Tell them how much they mean to you.
Even the ones who want to take ivermectin, which makes no sense to me. But if you want to somehow get your hands on some ivermectin, which I don't say, I should clarify that because I don't think you should be going to, an outdoor, an agricultural store where you can kind of buy stuff like that.
Right, because this is a veterinary medicine.
Right, and the same rules don't necessarily apply, but there are doctors out there that are prescribing this, and they're wrong. They are just plain wrong, but they're prescribing it. But, so somehow that's the road you want to go down. There's no rule saying that you can't take the ivermectin and still get vaccinated. That's one of the biggest head scratchers I've had, are a few patients who've chosen to take the ivermectin because they believe in that, but not the vaccine, and it's like, it makes no sense because the data is there with the vaccine, but not.
Right, and can you clarify that? I mean, the truth is that they looked at it, right, at ivermectin, because ivermectin has a role in some other viruses, some parasitic viruses and things like that, but it did not have an effect.
Ivermectin is used in humans to treat some certain parasitic infections, certain types of worms, to use the term loosely. It can be used for cases of lice, believe it or not. There's a topical form, which is used for dermatology reasons, things like rosacea, which is kind of a redness of your cheeks. So it does have human uses, and it has a major role in the veterinarian world. But it kind of similar to hydroxychloroquine, and that's why it's one of the things I find frustrating. Is I feel like we've already gone through this. We went through this with hydroxychloroquine, where people swore it, and they were, the president at the time was telling people to take it, and the data was looking good. I remember talking to you saying, I'm not understanding why this would work, and then we were beginning to say, well, maybe it has anti-inflammatory properties or blah, blah, blah. So same thing with the ivermectin. Remember, COVID infections, the virus. There was just some weird stuff going out. There was a study showing that symptoms are milder with people who take Effexor. Effexor is an antidepressant. I don't know. He was even bothering to study this stuff. But sometimes drugs have multiple benefits and multiple effects that we don't understand.
Right. And it was studied at length. And like our infectious disease specialist in town here, Dr. Marquette, if this was working and was going to help people, he would be prescribing it.
He would be, I think he said he'd be standing on the street corner, right?
Handing it out. That's right.
He'd be handing it out. That's right. Yes.
Is that what he said, right?
Absolutely. Yeah. He would be handing it out if it was effective.
All right. I'm trying to think if we just know it, because we're going to, try to not discuss this in the second half of the show because...
I would have one question, Dr. Stamberg, in regard to the progression of COVID. We have had, of course, the original COVID strain, and then we had the Delta strain, and then we have now the Omicron strain. What happened with the earlier strains?
Yeah. We're going through the Greek alphabet. Those strains are all out there. They just wound up not being too big of a problem. They wound up, the problem with the Delta was that it was more virulent. It was more aggressive. With the Omicron, a bigger problem seems to be that it's just more contagious. And even I was watching an expert interviewed on CNN, and he was talking about the spike is different, and the spike pierces the tissue of the nasal passageways. I mean, it's really getting pretty specific.
Absolutely. What about now these earlier strains? Do they still exist? Are they still propagating around the world? Are they still affecting people? The earlier strains, or are we really just dealing with Omicron now?
We are probably dealing, with Omicron right now. The strains, they kind of subside. Do they go away completely? I don't know. But it's just the way the virus kind of keeps adjusting. And we talked about at other shows about how the virus being a living species, although that's an interesting description, wants to survive. Kind of like the inherent rule of biology. The species want to propagate. So the idea that the virus wants to mutate into a more benign, benevolent form, so it doesn't so much kill us, it just kind of lives.
So
it's interesting. We're on the same page, aren't we?
Extraordinarily interesting. So I wouldn't. if I didn't get vaccinated, I would probably get the Omicron strain. I probably would not get that initial one that we had in 2020.
Probably. The strain out now is felt to be the Omicron strain. It's one of the reasons why they stopped recommending the Regeneron for people, because they said the dominant strain is the Omicron variant, and the Regeneron is not effective on it. So that was the thing I had been using for a year and a half to get people to treatment, was arranging for them to have the Regeneron treatment.
That's fascinating. That's fascinating. Okay.
Yeah.
Oh, we got a break now. So I will.
All right, we'll be right back.
Yep. We've got the 8 o'clock break, and I'll talk to you in a couple seconds. You're with us here at KCR, Kingston Community Radio, AM 920, 92.5 FM, and streaming online at mykcr.org. It's Monday, January 10th, 23 degrees. It's actually going down. And this last portion of Kingston Community Radio has been brought to you by Central Hudson. And we'll be right back after these messages.
Are you a renter or homeowner having trouble paying past due electric and gas bills? The Regular Arrears Supplement Program may help. If you're eligible for the program, you could receive up to $10,000 in aid. If you're behind in rent payments, the Emergency Rental Assistance Program may also help. Get the relief you need to help pay off those bills. Visit the Assistance Programs section of centralhudson.com for eligibility and application requirements. Do you know who that is? Who's that? It could be a clever thief impersonating Central Hudson, asking for your personal or account information or an immediate bill payment. Beware of scam artists that can target you by telephone, email, or in person. Don't provide personal information to callers or open email attachments. Ask to see ID. If you're ever uncertain about an inquiry, contact us. Don't fall victim to a sinister scheme.
Hi, this is Eleanor Arrow from the town of Ulster, and I support Kingston Community Radio, and so should you.
This upcoming portion of Kingston Community Radio is brought to you by Herzog's. Do you ever think about what really matters? At Herzog's Home and Paint Centers, community, family, and neighborhood all matter. Employees have been a part of the Herzog's family for years, and they value personal customer service and being close to their community. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home, building, maintenance, and painting needs. Discover the difference of buying local. And you can also visit herzogs.com for ongoing sales. You're listening to WGHQ, AM 920 and 92.5 FM, the home of Kingston Community Radio. My name is Dan Gatis, and it is 23 degrees on this Monday, January 10th, and we have Boyce Dairy Milkhouse famous cow pie giveaway. It's Monday, January 10th, and please wish a happy birthday to Marie Steedle from your friends and family, and husband Ed. And Marie, you are the winner of the the winter winner of the Boyce Dairy Milkhouse famous cow pie. Marie Steedle, you can go in and see them at Boyce Dairy Milkhouse at 62 O'Neill Street and pick up your cow pie for today. And thank you for submitting that. And let's get back to our hosts today. A little unusual when you don't have your hosts in on the studio. And here we are. And we are now in the 8 o'clock segment. You had one. Oh my gosh, that's great. Marie Steedle, Eric had one as well.
Yeah, well, it's actually I have a real cow.
You have a real cow in your living room.
It just moves.
Yeah,
I really want fresh milk.
Excellent. Okay.
All right.
Welcome back, everybody. Happy birthday.
So we have a guest calling in probably about 15 minutes. His name is Dr. Niraj Hashandani. He's a new physician, be practicing in Highland. And we're going to just have a conversation with him.
You know where that office is in Highland?
Yeah, it's on 299 there. As you go out of New Paltz towards Poughkeepsie, on the left. And
on top of the hill there.
You're right. They recently had Dr. William Heffernan retire. Dr. Heffernan was a community physician probably for about 35 years.
Yeah.
Can't give the actual amount of time, but he, that's a lot of patients now that
he's phasing his practice, right?
Right, and so he did a lot of important care to people over the years, but he's ridden off into the sunset.
It's hard to lose your primary care physician. You kind of grow up with your primary care physician.
35 years, a long time.
Yeah.
I've been doing this gig for about 25 years or so now.
Yeah.
And I have some patients that have been with me the whole time.
Yeah, you have them and their kids, right? And sometimes their kids.
Well, because I did the residency program in Kingston, and part of our training was that they do obstetrics, so we would have a woman during pregnancy, and then see her through to the delivery, and then after the pregnancy, often the baby would
primary
care. Under my care. So I do have some people in my practice. One young woman in particular is my daughter just turned 25, and that's how I always know how old this young woman is because she also just turned 25. So it's a long time.
Yeah.
Yeah.
That's good.
Yeah. All right. So we're going to talk to him, and
until he calls in, we expect him right around 8:15 or so.
Right. So then we're just going to shoot the breeze, I guess.
I thought you said you had an article.
I can't find it. Let me try to look.
Well, I was going to ask you a little bit about, it being New Year's, and I know we had talked a little bit last week about resolutions.
Okay.
And just working towards those more helpful type goals in the new year. I would love it if people would call in and let us know their resolutions where they don't believe in resolutions. Be kind of fun discussion. But I know for myself, not that I'm ever not trying to be healthy, but I found that, the pandemic was really hard on a lot of people. So just to try to, stay true to a good diet, exercise, up to like 3 to 5 times a week, and doing it like on purpose, not like, oh yeah, I walked from here to there, so I exercise a little bit, but, really doing it. And if you're just starting out and you haven't done anything, you can start in your chair and you can start modified and you can, maybe make a goal that if you're watching TV that during the commercials, you're going to stand up during the commercials and you're going to walk in place during the commercials and just get yourself up and moving because, we've had some family members who unfortunately fallen ill. And boy, when you're inactive, you can lose your activity so quickly. And I know that a lot of people suffer with things like back pain and, aches and pains. And then we find that even though sometimes moving aggravates those pains, that moving is better than not moving.
That's absolutely right.
So that's my resolution for this year.
Right. And that's all well said. We talked about it, I think it was our last show before New Year's, but really kind of, encouraging people not to be too hard on themselves either.
Correct.
Because, for example, when someone wants to quit smoking, I give advice and I say, make it a big deal. Choose a day. That's, maybe something important, not just New Year's, but it could be a birthday or an anniversary or Valentine's Day, or something. But at the same time, if it doesn't work, just choose another day and try it again. Don't. When it comes time to quitting smoking, don't forget that your healthcare provider, your doctor or healthcare provider, can help you in that, but there are some prescription products, which, by the way, are very good, and they can be effective. So Wellbutrin and Chantix are available. Weight loss is getting more and more complicated because the medical treatment of weight loss, the list of potential tools has increased. And I've had some patients recently where I'm trying to get some medication approved for them that I think will help them with their weight loss. When we had Jennifer Scheffler on, we had talked about that. These medications that are kind of for diabetes, but they really can help with weight loss. But
really, not easy to get, right?
Well, yeah, so we just received word from our guest. He's going to call in 5 minutes. Well, who do you think our adversary is in getting these medications prescribed?
The insurance company.
The insurance companies. Now, you would sit back and say, gosh, they really kind of, why don't they want their patients to be healthier? Why don't they want their patients to not become diabetic, to not develop arthritic problems or back problems or heart problems or acid reflux problems, to just list a few things that are worsened by obesity. And that's a good question. That's a really good question. Part of it is the idea that when you're on an insurance plan, it's not really a long-term commitment from the insurance company. You're really on that plan until if you're getting it on your own, like through the exchange, until next year comes and you choose another plan, or if you're getting it through your employer until your employer comes around and next year says we're changing companies. So that kind of affects that argument that the insurance companies, why are they not in it with you for the long run? But government's involved a little bit, really kind of requiring insurance companies to cover a lot of preventative stuff, for example, cancer screenings and lung cancer screening. But we really do have good tools for weight loss medicine. And there actually is a huge role for primary care to prescribe these medications. Part of it is, I always say the primary care is kind of like the USS Enterprise. Remember that show?
Yes, right. Star Trek.
Star Trek. The phrase was probably goes where no man has gone before. Primary care kind of goes where no one else is around to go. So the fact that if we're in a community where there's not a lot of specialists that would maybe specialize in weight loss medicine, the primary care will kind of step in and do it.
Try to help their patients.
So I'll give you guys updates on how that's going. It's a challenge. It's the whole idea of a prior authorization, a prior auth, PA, is an interesting concept, because if I already prescribe something, that is the authorization, and I'm prescribing it before the patient gets the medication. So that's a prior authorization. So the PA is an authorization coming from the insurance company to cover it. And it's a major burden on the current practice of medicine. Some weird things are requiring prior auth these days. Basic blood pressure meds, or the prior auth for an antibiotic. I mean, by the time, 3 or 4 days can pass, before the meds are kind of approved. And sometimes it's just a little, minor reason why they're not covering what I prescribe. I prescribe the capsules, they cover the tablets, that type of thing. So that's a little frustrating.
And, the public should know, the patient should know, is that the insurance company is not sharing this information with you ahead of time. And it's not like they're giving a catalog to a doctor and saying, if you want to prescribe this medication, this, and this has to be in place.
Yeah.
Or, right, is a good example. We cover tablets. We don't cover capsules. This is information that the doctor gets after the prescription has already been sent. And now the delay occurs because now the patient can't get the medicine that was prescribed for whatever reason. And unbeknownst to the doctor, they have to now go back and resubmit a prescription with those criteria in place if it applies. Yeah. The doctor can't make up something or some reason that the patient needs a medication just to satisfy the insurance. So,
and the ultimate offense or slap in the face is when we have to do a peer-to-peer review. So we have to kind of get on the phone. It takes time. You call, you wait, and then you're supposed to, I guess, be connected with some expert, maybe another doctor about it. But usually it's not. It winds up being a nurse or a nurse practitioner or someone who's not even that level of training, who's just kind of asking you questions. Is the patient pregnant? Is the patient this? Is the patient, and the answers can be kind of funny. Is the patient pregnant? No, because the patient's a man. That type of answer. But it's really at the end of the day a roadblock, and it really has a major effect on the practice of medicine. It's unfortunate.
And boy, as a patient, as someone who's calling their pharmacy to make sure the medicine's there so I can go get it. The doctor said he was prescribing it, and then call the pharmacy and have the pharmacy say to me, well, your doctor didn't do the right thing. Your doctor didn't submit the right information, and you can't get that prescription.
Right. And we talked about that, one of our earliest topics. We talked about triangulation.
Right.
The dysfunctional nature of a triangle relationship, and how the patient walks away from that discussion thinking the doctor did something wrong.
Right. And so it's so important to then call your doctor's office and calmly call your doctor. Don't get upset.
Right. Don't get upset. That doesn't help anything.
Your doctor doesn't want you to not have the medicine.
No, we wrote it to begin with.
Yeah.
I think we changed our minds.
Yeah.
We didn't mean it.
Right. There's obviously some roadblock, and it's usually not caused by the doctor's office. But, if you call your doctor's office, they'll be happy to help you figure it out. Just be patient with them, too. Everybody's in an influx of time crunch and a lot of phone calls and people waiting and long wait times. And so just hang in there, everybody.
The nurses in my office work very hard doing these prior auths all the time out of them.
Yeah.
But just, how are we doing over there?
Yep, we're good. And just wanted to let you know that our guest is on the line.
All right, great.
All right. Dr. Hachendani, can you hear me?
I can hear just fine. How are you?
Good. Let's see, Dan, maybe if you, I don't know, can you make it a little louder, I guess?
No, I've got it cranked.
All right.
I got it cranked.
All right.
Okay.
On the phone, we have Dr. Niraj Hachendani. He is a new physician to the New Vance office in Highland, and we want to give him a welcome to our community. So how are you, Dr. Hachendani?
I'm doing well. Just coming off a relaxing weekend. How about yourselves?
Good. We're under quarantine here. It's life in the age of COVID. Robin is on the line as well. You met Robin the other day on the phone.
Hi, Doc.
Yep. Hey, how are you, Robin?
Good.
So Dr. Hachendani actually has local roots. Where would you say your hometown is?
I grew up in Poughkeepsie, New York, actually.
Poughkeepsie, New York. Is there another Poughkeepsie, another state? That you went to medical school at SUNY downstate, right?
Yep, I stayed in New York. That's right. And then I missed the suburbs a little bit, so I ran out to the Jersey suburbs for my medical training, or for my residency in internal medicine. I was at Robert Wood Johnson Medical School for that.
Right.
And then I just missed New York, and so I wanted to come back to the mountains and the river, and here I am.
Yeah. So Robert Wood Johnson, we have that in common. Robert Wood Johnson is my medical school alma mater. So, how did you enjoy your 3 years in wonderful New Brunswick?
It was good. The food in New Jersey was phenomenal. So that definitely made it better. But all in all, the program was great. The people were great. I went because I really just liked the vibe there. My co-residents were wonderful, and it was a really good 3 years. COVID made it tough at times, but otherwise it was a good 3 years.
It's good to hear you say that, because residency is typically a rough time of someone's life. But when I look back at my residency, it was really a good 3 years for me as well. So it's good to hear that. So how long have you been with New Vance? When did you join us?
I only joined in November, so I'm about 2 months into my tenure here.
All right. And how is life going so far?
So far, so good. It's picking up speed with Omicron taking over. My visits are being cut shorter, and I'm doing lots more telemedicine, which is a good skill to work on. But, they let me ease into it, so I feel like they've let me adapt fairly well.
Good. That's good. And you know, are you kind of are you filling the shoes of Dr. Heffernan to some extent?
I'm filling one of them. There's 2 doctors here to replace him. So I joke with my patients that Dr. T right next to me and then myself each have a responsibility of filling one of those shoes.
Good.
You each have one footprint here.
You know, that's a challenge, but I'm sure you're up to it. You know, people are very committed to their primary care provider, you know, so now this is an adjustment for them.
Very true, very true.
Yeah. So tell me why you kind of wanted to do primary care. What attracted you to staying as a primary care physician?
Yeah, actually, I initially was thinking I was going to be critical care bound or at the very least doing acute hospitalist care. But I realized in that model I just wasn't developing any patient relationships long term. And I realized, just thinking back to my initial medical school application essays, I realized that's probably why I did this job. And it was getting tough just to see patient after patient kind of patching up some of their acute issues, only to send them home, not necessarily address their socioeconomic difficulties, and not being able to ensure that they have very good preventive care, and just see them wind up back in the hospital. Because that was just a little bit sad, because at the end of the day, the hospital is not a fun place to be. No one wants to end up as a patient in the hospital. And so I just kind of just refocused, and I thought, this is not a fun place to be. I'd like to keep people out of here. It's good for society. It's good for individuals, and it means living more fully if you can just maintain your health with an established preventive care provider. And that kind of motivated me to spend a little bit more time pursuing primary care, because truthfully, the one thing about Robert Wood was it was very much an inpatient-heavy program, I felt. We definitely had plenty of primary care time, but most of my electives I admittedly spent inpatient. We had lots of floor time, meaning working as a hospitalist, even compared to some other programs, and we had maximum ICU time that was even allowable at that program, which at the time I really enjoyed, because acute care is really fascinating. You really dig into some amazing science. And when you win big. I mean, you save people from the brink of death. So it's an adrenaline-fueled moment in the ICU, time after time. But I mean, I missed those patient relationships, and ultimately, I wanted to keep people out of the hospital. I just think that's really important.
Sure. You know, we always talk about that on our show here. You know, the idea of wellness. You know, and sometimes you'll hear criticisms levied towards traditional doctors like you and myself. You know, that we only focus on illness, and I always kind of say that couldn't be further from the case. We absolutely want you to be well, and that's a big part of what we do every day.
Right, and if
Absolutely.
It could be measured, how much time do you, as primary care physicians, invest in keeping people out of the hospital, and is that actually measured?
Right.
Like how many, times did you speak to a patient or counsel a patient that actually helped them to stay out of of the emergency room, or they didn't have to go to the hospital because they had an appointment with you? So.
Yeah, absolutely. I mean, in my second week here, I had a patient come into the hospital with a blood pressure of 240. I tried to get him to the hospital. He refused because he just hated it, which I also understand. So I called him every single day for the holiday weekend, I believe, and was just like, hey, what's your blood pressure today? I want to make sure I didn't drop you too fast. I want to make sure this medicine's working for you. And he was very dedicated. He checked his blood pressure every day. He took his meds every day, and I got him down slowly and safely through the week. And thank God he has no complication. But that's a clear indication for hospitalization. And yeah, but none of that work is captured. Those phone calls, et cetera, the extra side work that you do. But I mean, it's very satisfying to keep someone out of the hospital like that.
Right. I agree with you. Same thing like when you and I know it, but like a COPD patient someone having an exacerbation, where, if they didn't have a primary care provider, they probably would wind up in the emergency room and maybe even wind up admitted. But there are plenty of times in my career where I've just kind of treated as an outpatient with just close follow-up. But it's hard to measure that, things that didn't happen. You can measure hospitalizations and length of stay and hospitalization rate. How do you measure non-hospitalization rate? It's not so easy.
Yeah, very true. Yeah, and that statistic would very much demonstrate a lot of value to people who maybe don't value primary care enough in the system.
Right. You want to ask a question?
I worked with a internist for about 6 years when I was working at the doctor's office, and one time I asked him why did he want to become a primary care doctor, and he said that he was doing a specialty in a hospital in New York City. What's that called after residency when you go into something specialized?
Fellowship.
A fellowship, right. And he said that every time he helped a patient, he would give that patient his advice during the fellowship, and the patient would look at him and say, okay, I'm going to run that by my primary care doctor, and I'll get back to you. And he thought to himself, well, I want to be that guy. I want to be the guy that everybody's checking in with. It's just
funny.
It sounds exactly like how you feel about it.
Are there any kind of, within the realm of general internal medicine, are there any areas that you have a specific interest in?
So I was critical care bound for a little while, and I was that way because I really loved fluid dynamics, so that led me to a lot of heart, kidney, and lung issues. So I really enjoy those cases. But I'm still actually trying to find my niche. I'm looking to explore some additional training, even though I'm wrapped up with residency. But I'm looking into getting certified potentially in point-of-care ultrasound in the clinic. And then my colleague who started with me a few months prior, he does some pretty cool injection stuff, which I was also thinking about getting into down the road.
Well, we gotta talk. I like to do injections as part of my practice, but you're right. The whole idea of bedside ultrasound or office-based ultrasound and how that's changing things. So that'd be great to kind of share our agendas and see if there's something we can come up with together.
Yeah, I mean, I think it could be the new stethoscope. It could be something that a lot of primary care doctors and internists just kind of keep in their pocket. Just being able to see the heart and really assess fluid dynamics for someone who's prone to volume overload or who might be dehydrated, especially in your heart failure patients and your kidney patients.
Interesting.
I think it could. And if you ever just want to take a peek at the gallbladder because someone's having some abdominal pain or something like that, just having that as a tool to help visualize for someone who's, acutely not feeling well would be a good thing to have, I think. That's great.
It's good to hear. And then, we're colleagues now, so it's important that we kind of share our ideas. And, for me to have some really vibrant young colleagues is rather exciting. You guys have trained in this century. And, there's things that were just not around when I was in training. So I can't wait to, share some of those ideas with you. So what's your day look like? You're starting patients any minute now, aren't you?
Yeah. I think my first one's due in about 3 minutes.
Yep. And you'll be seeing patients. How many days in the office are you?
So I'm Monday through Thursday, and I'm about 8 to 5:15 is my last patient. So I hope to wrap up at 5:30, and then I usually hang around a little while just because there's always more paperwork. But my scheduled patient times are from 8 to 5:15.
Your last patient is what time?
5:15.
5:15. All right, and so you, where you call home now? Are you still living in Poughkeepsie?
I stayed in Dutchess County, but I went a little farther south. My wife and I are renting in Beacon right now. We're looking to buy a house, but I'm sure I don't have to tell any of the listeners today that the housing market is a little bit competitive right now. So we're looking. My wife still goes to the city every so often for her work. So being a little closer to the city, like further south, was just helpful. And Beacon has
Gene
a
medicine
shuttle
too?
that takes you from anywhere on Main Street down to the trains, which is just wonderful.
Is she in medicine as well?
She's not. She's in investment management type of work. And so she does a lot of work in sustainable investing, like green investments, environmental justice, and things like that.
So, Doc, if I needed a new primary care doctor and I wanted to establish care with you, is there a long wait?
There is not. Most of my patients are coming through our former Dr. Heffernan patients, but I think people can come in within a few weeks to see me, no problem.
All right, great.
And do you know the office phone number there? So if people want to make an appointment with you?
Yeah, let me just make sure I give you the right phone number.
I don't always remember my
say
own
the wrong
number.
thing and send you over to Caramel or something.
Yeah.
Let me just pull that up. So we have 845-691-9200.
Okay, 691. All right. So I just want to, and Robin as well, we want to welcome you. Look forward to a long, fruitful career. I look forward to a time where I can meet you in person as a colleague. But really, everything you say just sounds like you're an excellent physician in addition to our medical community. So good luck to you.
Yeah, thank you very much, and thanks for the warm welcome. I appreciate it.
All right, and if you anything with that ultrasound, let's if we could work together and get some trainings and stuff like that, that'll be pretty cool.
Yeah, I'll show you around the ultrasound if you want to show me some injections.
All right, deal. But you already have the machine?
I was told we actually do have a butterfly ultrasound. I haven't used it in the primary care setting as much. I've done it inpatient a little bit, which is why I want to get a little more training.
You're kind of extrapolating some of your exposure in critical care over to the primary care setting.
Right, exactly.
Okay. All right, well, get to work.
Exactly.
Well, thanks very much for having me. I really appreciate it.
All right, and good luck. We'll be in touch.
All right, sounds great. Thanks so much. Have a wonderful day.
Right.
Thank you, Dr. Hashandati. You're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM WGHQ. It is 22 degrees right now here on this Monday, January 10th, and this last portion of Kingston Community Radio was brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building and maintenance and painting needs and discover the difference of buying local. And visit their website at herzogs.com for ongoing sales. We'll be right back after these messages.
If you came across someone struggling with hunger, how would you recognize them? By their clothes? Their age? The way they speak? Would you notice a 16-year-old boy who got his first job,
not for extra spending money, but to help feed his little sisters?
Or a mother who's in between jobs and sometimes goes to bed hungry so her kids can have dinner? Or a 14-year-old girl who signs up to every after-school activity not to make friends, but just to get something to eat? Or a retiree who fell ill and had to choose
between getting medicine or groceries.
I am the 1 in 8 Americans who struggle with hunger. People you pass by every day but never knew were hungry. I am hungered in America.
Hunger can be hard to recognize. Learn why at IamHungerInAmerica.org. Brought to you by Feeding America, 200 Food Banks Strong, and the Ad Council.
Hi, my name is George Post from Ulster Park, New York, and I support Kingston Community Radio, and so should you. Where else can you speak to your local representatives on the air and have your questions answered? So thank you, and support KCR.
And thank you for supporting KCR, Kingston Community Radio, AM 920, 92.5 FM, and streaming online at mykcr.org. KCR's talk radio, so call in 331-9255. 331-9255 is your number. And this upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one right near you. Now let's get back to Robin Baker and Dr. Eric Stamberg. Welcome back.
All right, thank you. That was we had an interesting guest and a fine young physician. Welcome him to the medical community, Dr. Niraj Hachandani. He is. There's another new physician at that office as well. I wish I could say the name accurately, but please, if you're down in that area looking for a new primary care physician, give them a call. And again, there's, we have. It's interesting with medicine, right? Sometimes the newer docs are all right. It's a field that's always changing, and there's things that they've known that were part of their training that really were not even around when I trained. Not to mention doctors, 10, 20 years older than myself. So something to be said to a good young doctor who's trained within the past 5, 10 years or so.
Dr. Stamberg, I can't underestimate the amount of education you continue to absorb as well.
Absolutely.
As well. Okay.
I got to take my board.
That's important. That's very, very important to realize that you're always updating.
Right. And it's important. It's and it is a combination though. There is also something to be said to just kind of having some
experience,
some water under the bridge. Some things that I've seen before, and so that's it's kind of a little bit of both. And by the way, another thing I've learned over recent years is how important your milieu is in which to work. In this case, practice medicine, but I think it applies to everywhere else. It's one of the many, many lessons from COVID, although it kind of existed before COVID, which is how important we are all to each other. Who you work with, really makes or breaks, the difference in how you experience your day at the office, so to speak. Would you agree with that?
Right. You just asked Dr. Hachandani how his day was looking. So how does your day look? I mean, your days have really kind of changed over the past year.
Yeah.
Out of pure necessity, you had to add the telemedicine model into your practice. And, you've got very full days. Like I asked Dr. Hachandani if someone wanted to become a new patient of his, was there a long wait? I mean, this is very frustrating to patients.
Yeah.
They lose their physician because of their insurance or someone moved or your job changed. So it usually is always based on insurance. But if someone wanted to become your patient for the first time, there's a long wait, isn't there?
Yeah, my practice is pretty full, and the wait, I don't even want to know how long the wait is, But again, I've been doing this for, I think this is my 24th year. So the fact that my practice is almost full kind of like is not a surprise, right? But it's a challenge. It's a challenge for any healthcare practice to meet the needs of existing patients and meet the needs of potential future patients. And by the way, there is a shortage. I mean, we feel it. It's not that easy to get a new provider, and it's not that easy to get an appointment with your provider that you already have. It's a struggle.
Right, because your day is really booked with physicals and wellness visits and those acute appointments. Oh, I sprained my ankle, or
we have a system that has urgent care to fill some of that void, right? Although that's a little, something like an ankle sprain, for example, is a reasonable urgent care visit because you might need an X-ray. I would say might because it's always. By the way, it's a little aside, but when you and I talk about doctor-patient etiquette, don't tell the doctor what you need. Why are you here today? Oh, I need an X-ray. Don't say that. Say I hurt my ankle, and then we'll take it from there. Anyway, but the idea that urgent cares were going to kind of take some of the steam out of the kettle of primary care hasn't quite worked out. By the way, primary care did get harder. There's more to do. There's more things to go over. Lung cancer screening is a great example. That didn't even exist, and now it exists. And it's there's not more time now to go over it. It's just something now that gets squeezed into the same time as you already had.
I find it interesting that patients are not real patient with their primary care doctor's office. But if for some reason there's something up with them and they need to go to urgent care instead, they're willing to wait like 2 hours.
I mean, they're happy to wait, but there are times they go to urgent care, especially now with the COVID surge.
Yeah.
It's a little bit of a kvetch on our side, is that we feel that patients, sometimes are impatient with us. We are not not in the back room with our feet on the table eating bonbons or smoking a cigar. We're working hard. And if there's a wait, it's not because we're not doing what we're supposed to be doing. People can sometimes go to a specialist office and they wait a long, long time, but they kind of say, well, this is just the way it is. I go to CVS or Walgreens, and I wait in line just to, buy some toiletries or whatever.
Right. So that's kind of how it is sometimes.
Yeah. So really try to be patient with your doctor and your doctor's office. Try to be patient with callbacks. Generally I check messages every half day, at lunchtime and at dinner time, at the end of the day. So, if you make a call and it's really not, something that has to be addressed right that minute, be a little patient. Don't kind of call multiple times. That just kind of clogs up the inbox even more. So it defeats its purpose.
What would you offer as advice for your patients this year as far as their New Year's resolutions, as far as your office is concerned? Do you want them to make sure that they're prioritizing their cancer screenings and their wellness visits? And, do you see patients every 3 months, every 6 months? What is
it? All depends. But everyone should have at least a visit once a year with their primary care provider, even if you're the most healthy person in the world. Sometimes I call it a hello visit. We checked your blood pressure. We reviewed everything. We did a basic exam. Everything seems to be fine. So that's something to make sure you prioritize, an annual wellness visit. And, things are busy right now. So if you schedule it now and you have to wait till July, so be it. Write it in your calendar and wait for the appointment.
Right. And how often are you lucky enough to kind of find something, a little something that, is not bothering the patient at all, but boy, is something that you could potentially hurt them and really help them?
Yeah, well, it happens. A good example is just a basic exam, listening to someone's heart, and you hear an irregular heartbeat. So then you do an EKG, and sure enough, the person's in atrial fibrillation or some other condition. So a basic exam can yield results, or just things like the blood pressure. There was a recommendation that came out a couple of years ago telling people they didn't need to have a physical. It was kind of like the way Dr. Tack reacts to the recommendation from the CDC. I remember that recommendation coming out and not really liking it. What they were referring to was a traditional head to toe physical, as Seinfeld would say, take off your clothes and sit on the butcher paper. Wait for your appointment. But the idea that a physical really is more of a wellness visit. It's a targeted review of you and your health. It's a relevant physical exam. It's a relevant testing if necessary. So that is still, in my opinion, very important. And by the way, Medicare values it. They call it a wellness visit. I wish we wouldn't get so wrapped up in the semantics of everything, because I think it leads to a lot of confusion. I tell patients this is technically not a physical, but it's good enough. We're going to, accomplish the same thing in a wellness visit that we would accomplish in a physical at the end of the encounter. So we can call it whatever we want.
We'll call it what Medicare wants us to call it to get it covered.
Well, Medicare has checks that on the checklist that have to all be met. So that's, and some of them are a little kind of hard to describe, a little kind of cryptic, like counseling about at-risk behaviors, that type of thing. What does that mean? If you have someone who doesn't smoke, who exercises regularly, eats a good diet, blah blah blah. The counseling is to continue that. So that's advice I would give everyone who's listening, to have a primary care physician and to have at least an annual visit. If you don't have one, get one. And if you have to, things are backed up now. If you have to wait for the appointment, then that's what it is. This is the way things are right now. as to how often you get seen really depends. If you're completely healthy, annually is absolutely fine. Some people I see every 6 months. I tend to think in 3s. Other doctors think in 4s. So I usually will have someone come back either in 3 months, 6 months, or a year. So if someone has typically for diabetes, for example, you check the A1C every 3 months. So usually every 3 months is a good interval for someone with diabetes. However, if the diabetes is stable, is well controlled, you could potentially go to every 6 months, provided that the person is keeps up with it. Sometimes I do the every 3 months just to keep them on track, give them some ongoing encouragement.
Yeah, definitely.
So, be patient with your doctor's offices. It's a complicated system. A lot of the delays are completely beyond their control. This time of year, people have to sign new forms when they come in. That's all of that, I think, is required by the government and HIPAA laws and things like that to have an annual agreement signed. Remember that, Robin?
Yeah.
Understand that the beginning of the year brings usually a new deductible that might need to be met. So if you all of a sudden are being asked to pay a bill that you thought maybe was supposed to be, not exist, that's probably the reason.
Yeah, and the annual Medicare deductible. Last year it was $203. I'm not really sure what this year is.
It tends to go up a little bit every year, 206 or something like that. The wellness visit technically does not have a copay. It does not come out of your deductible. Where it gets kind of complicated and a little confusing is when you go over other things in the because people do that, and it's understandable. They go to their doctor's office and they kind of say, "Can you look at this? Can you check this? Or this hurts, or whatever." So already the confines of the visit are kind of expanding, and then that can kind of lead to this kind of gray area. Is this something that should be a separate visit? Should we do it on the same day? If so, it might be a separate charge, and that's just the way it is. It's you go to your mechanic and you need a tune-up and have your tires changed. Those are two separate charges. Well, that's not a good example because tire rotation might be part of the tune-up.
Right, but they find out that your brakes aren't good.
Right, there you go. That's a good example.
And they're not going to do the brakes for the same price they were doing the tune-up for.
Right,
so.
Right. They're not going to say, "Hey, the tune-up's $150. Your brakes are bad, so." It's $150. So you have to kind of understand that this is just the way it is.
It's a fluid situation.
Mm-hmm. There are plenty of times where I don't bill for a separate visit, where I easily could. Plenty of times. Matter of fact, frequently. And my guess is most primary care doctors are doing something very similar.
Right.
Because at the end of the day, we are committed to you. We're committed to the patient. We're not, contrary to what people might say, we're not in it for the money. Hate to break the news to people, and including Dr. Hutchinson, if we were in it for the money, we probably would have gone into primary care. We would have gone into much higher paying specialties.
Right.
When people ask me, do I get paid enough as a physician? I say, yes, I do. If they say to me, do you get paid enough as a physician compared to other physicians, from other specialties, I'll say absolutely not. Primary care is tremendously underpaid. In proportion to the value that it brings to the healthcare system. So that's just something to keep in mind.
One of the commercials that's on our show brought by the Primary Care Association said that, almost every difficulty that exists in the healthcare industry could be solved by having excellent primary care and enough of it that, people had access to it and could really take advantage of it.
It's kind of the Dorothy Gale solution, right?
You had it all.
You had it all along, with right in front of your face. Good, well-trained primary care that's able to practice in a way that they need to practice to provide adequate care.
Do you think everybody knows who Dorothy Gale is?
I don't know. You want to enlighten them?
She's Dorothy from The Wizard of Oz.
That's right. Her last name was Gale. Robin likes that trivia question.
And at the end of the movie, the Good Witch of the North tells her, you had it all the time.
You had it all the time. So, to me, that's the solution to our healthcare system. How we're going to get there is a different issue because it's going to require a lot of training, a lot of resources. It's going to enable primary care doctors to maybe not be so busy in order to do what they need to do. It's
Right.
funny because you talk to people like in the therapy world, they limit their cases to, I don't know, whatever active number. They're very conscious of not taking on too much. Even, I've had something I needed to do in my backyard there. It's been hard to find someone because they're just too busy, So you just...
A contractor.
Yeah, contractor. So, the idea that we also need time to do the job right. A contractor will sit there and say, I'm busy enough right now. I got to focus on what I got, So it's a challenge, and Dr. Hachandani, what a great young doctor he is to be, kind of committed to the primary care and wellness of the patients that are going to be under his care.
Well, it really does make a lot of sense when he was able to answer that question for you, and he said that, taking care of those acute issues is fine, and I'm happy to do it. Emergency issues, acute issues, but really taking care of somebody and maybe preventing them from having an acute issue occur is really where his passion lies. So, and I think most primary care doctors would give you that same answer.
Yeah, that's right. And we like what we do. We do. It's a challenging job. It's gotten hard. I've been doing this long enough to tell you it's gotten harder. Everything's gotten harder. So we're not unique. I mean, many other jobs have gotten harder, but there's just more to do medically. Medicine's always growing. There's always, I gave an example of lung cancer screening. Choices of medications always growing. And then the business side of medicine keeps getting more complicated. Things that I have to check and click and make sure that they're in place in order to do something. We talked about prior authorizations, how much they interfere with the flow of the office. When you're waiting for your primary care doctor's appointment, he or she might be on the phone getting a prior authorization. So you have to be understanding of those things.
Yeah. What do you think is your biggest challenge?
I think time. I think time is our most important commodity, and lack of time is in a way our biggest enemy. That they give patients what they need and what they deserve in the context of a busy day at the office is the hardest challenge. And that includes, visits outside of a visit, giving people the right time to review their labs and give them a proper explanation or get through phone calls in a timely manner. I mean, I do have a staff at the Kingston Primary Care, nurses and front desk personnel who work very hard to meet the needs of my patients and the other patients at the office. And I can say that of every single doctor's office in around, whether in Kingston or Ulster County or beyond. So.
Right. So as far as resolutions go for this new year, you want your patients to be sure they have their screenings done.
Right. An annual visit, if it's not scheduled, you go, pick up the phone and schedule it. By the way, we're starting to do some online scheduling as well. I know nothing about it. So.
Oh, I think you can go online and make your own appointment.
Mm-hmm. And if there's a wait, there's a wait. I mean, that's what it is. It's not, it can wait, but to have it on the books. Be healthier to yourself physically, whether it's diet, exercise, limiting alcohol. Alcohol consumption has gone up dramatically.
I love
in the COVID era. What, Dan?
I love the idea of making resolutions that are fun to do. That you're, like instead of saying cutting down on food, say, okay, I'm going to take the dogs for a walk 3 times a week, rather, and that allows you to cut down on food because you don't, like you're not sitting around the kitchen and stuff like that to eat, and all these kinds of positive resolutions where you say, okay, I'm going to do this. This sounds like fun, and it has a counteractive results to the things that were affecting you, or or being a negative aspect, rather than just saying, "Oh, I'm going to stop smoking," or "I'm going to get to the gym." Have fun with it.
Right.
You're
right. And,
have fun with those resolutions.
And just focus on our stress too. We're pretty stressed out. I mean, would you agree with that?
Mm-hmm.
I would too. Yes.
So, I like to prioritize your relationships. If you have kids or whatever, make sure that you all have a family dinner. A couple times a week. Because everyone, especially as kids get older, they're all pulled in different directions. If you're in a relationship, prioritize doing things for that individual that you're in a relationship with. So yes, so it's a new year. Right now it's a frigid year. It's looking awfully icy out there.
Yes, I was going to mention that during the weather. I wore my what do you call them? Like the spikes on your shoes. Because if you get out there, it is very, very icy. So wear those little spikes on your shoes if you have them.
Oh, you like those things that strap on over your shoes?
Yes, absolutely. I forget the name of them right now, but there's many different versions. Yeah, and that then you don't have to worry about the slippery ice because it is icy out there.
It is. It's just that everything has like a shine to it, from the ice. Yes, well, I guess that's a medical point. And be careful out there, right? Don't slip. This time of year, the ER is full of, people and urgent cares. People slip and they land right on their back, kind of almost like a pratfall from a cartoon or a old vaudeville act, those.
Right, and you're in danger of really hitting your head.
Hit your head, hit your back. When we do get our first major snowfall, remember the shoveling there. If you're out of shape, you probably should, and you're going to shovel, you probably should go out in a couple movements, intervals, rather than wait for the snow to finish and then go out and try to shovel 6, 7, 8 inches.
Yeah, a little bit at a time is very, very, very wise. A little bit at a time, not everything because you see it there.
Unfortunately, the first snowfall of the season is usually a heart attack time. Not to scare people too much, so don't ignore symptoms. But it's a perfect storm. It's physical exertion beyond what people have been doing. It's cold. The heart works harder when it's cold. It tends to be in the morning. Which more heart attacks occur in the morning. So it's kind of like a perfect storm.
Oh, wow. The heart works harder when it's cold.
Yep.
Oh, okay. Yeah.
So just these things to keep in mind. So who knows? Next week maybe we'll have a show with 6 inches of snow on the ground. So next week's show we do have a guest as well. It's Dr. Liz Levine and probably some younger colleagues from the Family Practice Residency Program at Northern Dutchess Hospital to talk about some initiatives they're doing with end-of-life counseling. So we look forward to that. Hopefully Robin and I will be lifted.
That's fantastic. That is fantastic. So just for all of our listeners, Dr. Eric Stamberg and Robin Baker have been speaking and doing the entire show remotely, beautifully, incredibly. And our call-in guest was also remote. So that was an extraordinary moment of time here.
Sorry, it's lonely for you, Dan. You don't get to witness Robin's antics in the studio.
Yes, I know it. Mostly your antics, Eric.
Thank you.
Yeah, no, it was a great show. It was a fantastic exploration, especially with family practice, which is extraordinarily useful and very, very important to stay on the front line of people's health.
Okay, so, all right, so I guess we'll get going back to our quarantine.
Yeah, okay. All right. Good luck with that. I know you're. I know you're doing fine. Okay. And thank you. Thank you.
Right.
See you next week. Okay. Bye.
See you next week.
You've been with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. And thank you for sharing the morning with us and participating in Kingston Community Radio and our live streaming online at mykcr.org. Talk radio at its best. Inspired discussions of, by, and for the community. It's Monday, January 10th, 23 degrees right now here in Uptown Kingston. And this last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. I did pop up the cancellations for today, and the Center for Spectrum Services Kingston site is on a 2-hour delay. Woodstock Day School is on a 2-hour delay. Saugerties Central School's 2-hour delay. Onteora Central School District is on a 2-hour delay also. And Rondout Valley Central School District is on a 2-hour delay. I didn't pop up Kingston, but I would expect that to be the case as well. We invite you to keep up with us every weekday, 7 to 9 a.m. every weekday on KCR, Kingston Community Radio. Tomorrow is a terrific Tuesday with Nina Postjapak and Cameron Rylands. Until tomorrow, we wish you every success in growing and developing Kingston and all our neighboring communities. We now return you to Magic 92.5.